Going Under, Anesthesia Answered with Dr. Brian Schmutzler.
And I'm Dr. Brian Schmutzler. Going Under, Anesthesia Answered is sponsored by Butterfly IQ. When it comes to successful ultrasound-guided procedures, precision is everything. That's why IQ3, Butterfly's handheld POCUS device, contains advanced features to support procedural success. With Butterfly's needle out of plane preset, you can visualize the needle tip within 1 millimeter after insertion. Butterfly's biplane imaging, the only multiplane imaging in a handheld ultrasound, lets you see both short and long axis simultaneously in real time. And Needle Viz enhances your ability to track the needle in plane, from early entry point to the region of interest. Butterfly IQ3 also delivers image quality similar to cart-based POCUS systems at 1/10 the price. And, unlike a cart, you can carry it in your pocket and anywhere around the hospital to conveniently use where you want, when you want. So whether you're inserting IVs, performing regional anesthesia, conducting cardiac assessments, gastric evaluations, lung ultrasounds, or anything in between, the Butterfly IQ3 is the perfect probe for your practice. Visit store.butterflynetwork.com to claim a soft case with the purchase of IQ3. Use code BRIAN25 at checkout. Terms apply.
And welcome to a new season of Going Under, Anesthesia Answered with Dr. Brian Schmutzler.
We're back. We're back.
And I'm Vahid Sadrzadeh here with Bronson Taylor, who you may remember from last year's podcast in Atlanta. You were with us live, sir. How you doing?
Doing good. Excited to be back.
Yeah, we're excited to have you back on a new season of our podcast. You may see some new shiny digs that we're in. Still a work in progress, but new studio, new season, and of course, new topics here on the show. Brian, we're going to start with some new variants of a lot of different disease. I feel like we're back in 2020 again.
I know, yeah, it feels like COVID all over again. Yeah, well, and you know, we're filming this in wintertime, and so obviously in wintertime you end up with a lot of viruses. They go around just because people are cooped up, particularly in the north here, cooped up, it's cold, change in weather. I think today we want to talk about two big ones and then one sort of new thing that's coming out now. The two big ones we want to talk about are norovirus and influenza, particularly influenza A. And then we'll talk a little bit about, and I actually have to look at what the name's called, human metapneumovirus that's been appearing in China. So it's giving me the COVID vibes here, but it's something, it's been around for a little while, but it's kind of burgeoning at this point. So we wanted to talk a little bit about that.
Introduce Bronson again for the folks who don't remember him from the last podcast. But
who you guys forget Bronson.
You guys are business partners with JEBS Anesthesia. Tell us a little bit about JEBS, and I know we're talking off air, but when you guys started and kind of how you came together, how you met.
Yeah, so JEBS Anesthesia Consultants, we're an anesthesia management company. We're a staffing service, and we're a consulting company. I call ourselves the unicorns of anesthesia. Brian and I have been business partners since late 2021, early 2022.
Yeah. Mm-hmm.
And post-COVID, man, as everybody knows, everybody needs anesthesia. Business has been booming, especially in the staffing realm. Constantly people are asking us for more providers, asking us for more help, more anesthesia outside of the OR as well. It's growing like crazy.
Yeah. Bronson and I have known each other probably five years now. We also work together in several other capacities. Aside from being good friends, we also work together for CCI Anesthesia, and I think Kurt's going to come on again this season.
Nice.
The CEO of CCI. But we do some administrative work as well for CCI Anesthesia, and we spend a lot of time together. Our wives joke that we talk to each other more than we talk to them. So
they call us soulmates.
Yeah, soulmates.
This sounds like a great thing here. How do I get involved?
You are.
Actually, I am involved.
Yeah, you are. Yeah.
Honorary. No, we do the social media, actually.
That's right. No, I mean honorary anesthesia provider.
Oh, yeah.
It's not that hard.
Don't tell our secrets.
Yeah, don't say that too loudly, Bronson. Bronson is a fellow Jeep guy, so you'll be able to. Maybe you should hop on the Jeep train.
You guys want me to? I can go in the other room while you guys.
Maybe you should hop on the Jeep train at some point. What do you think? Maybe instead of getting a new pickup truck, you should get a Jeep.
Yeah.
They have a V8.
Too much. Oh, yeah.
Yeah.
I probably would then, actually.
It's one of the few remaining V8s in the world.
In production.
That's right.
Outside of trucks.
That's why I'm not getting another Tundra, because the Tundra didn't come with a V8.
Have you driven the V6?
Yeah.
And? Yeah. It's just not the same.
Feels different.
It's not the same. The variants are not the same either. So when you're, let me ask you this question though. When you're looking at year to year,
Yeah.
and both of you can answer this question. When you're looking at year to year variants of like neurovirus or H1N1 or whatever it is, or this new variant that's come out in China, HMPV, what are you looking for different? And does the previous year's flu shot, right? If you're getting a flu shot and the provider is saying to you, get your flu shot this season.
Flu shots are a complete gamble. They do their best guess of what's going to be.
So what's in it, though? What's in the flu shot that you're getting, and is it based on whatever the...
Yeah, it depends which one you get. So there's a live attenuated one, which I don't think many people get anymore, and then there's one where they... And I'm not a virologist or a immunologist, so I'm not describing this perfectly, but basically they take a piece of that influenza and then create antibodies from it and inject you with a sort of something similar to that to fight the flu. The only way they do that though is they go back and guess, right? So like, you know, I don't remember all the different variants, but let's say there's two there's two proteins on each flu virus, the H protein and the N protein. That's where you get, like you said, H1N1, right?
Yeah.
H1N1 is the first flu they ever identified. I believe it's in 1918. You know, the flu pandemic that happened in 1980. That was H1N1. So then they've named each variant since. So the next one was whatever, H2N1, H2N2, H3N7. There's a bunch of them. So they take that and they try to guess what exactly. They try to guess what this year's flu is going to be. So, you know, let's say they guess it's H3N5 or whatever. I'm just making this up, right? I don't know what the letters and numbers are exactly, but and it's actually H1N1. Your protection from that's going to be pretty minimal. Now, the reason they tell you to get it is because they claim that there's not a lot of harm to getting the vaccine. It may not work, but there's not a lot of harm to it. So that's why they're telling you to get the flu vaccine.
Okay.
I think what I look for as people start coming in is how sick are they getting and how many people are getting sick, right? So let's say in an average year, the number is X. But this year it's 3 times X. That means that the flu is more virulent, right? Meaning that more people are getting it. It's more contagious. So either we screwed up the vaccine or it's just a more contagious virus. And then how sick are they getting, right? Do we have hospitals full of flu patients, or do we have, you know, the normal amount of flu patients? So those are the things that I look for when it comes to a respiratory virus like influenza.
My experience is the same thing. When I worked in the ICUs as a nurse, depending on the year, there would be multiple H1N1 sick patients, or there would be very few. And kind of that was your gauge of how the year was going to go. And it usually hit about this time of the year when it's the coldest. Everybody is, you know, cooped inside, and they might not be taking the best care of themselves, not getting sunlight, things like that. So, like I said, it's a guessing game. We do our best to guess it. As far as us as anesthesia providers go, I'm always looking at how full is the hospital, because then that starts to dip into, hey, are we going to start canceling elective cases? Are we going to...
Because we don't have anywhere to put the patients. Yeah.
So when you're looking at this, I don't know, these different variants or whatever, you were going to say something about, you know, it's always a gamble.
Yeah.
And what is the gamble? Not like you're going to get sick and it's not going to work? Like, because the theory is you always get sicker from the shot.
Yeah.
Right?
You always get the flu after
you always get the flu after the shot.
Yeah. So
are they basically giving it to you?
Unless you get the live attenuated virus, you're not going to get the flu from an influenza vaccine. What people usually get is an inflammatory reaction. So your body, when you inject something in your body that's foreign, your body recognizes it as foreign. So your body's going to say, I don't like this, and so it's going to create a fever and fatigue, malaise. It's going to feel like a real sort of minor case of a respiratory virus or the flu. You're not getting the flu though, right? You don't get the flu from the flu vaccine. Well, in my opinion, what the worst thing that can happen is that, well, I mean, there are certainly cases of Guillain-Barré, which is a neuro disorder you can get from a flu vaccine, and some other things. But in general, the majority of people, the worst thing that's going to happen is it's just not going to work well against the virus, against the flu virus for that year.
And I think people who are sicker, who have a lot of comorbidities, it's smart to get the flu shot just because your risk is higher. It's going to affect people that have those, obesity, diabetes, any respiratory diseases. They're going to be more at risk of having a really bad reaction. And there's nurses I worked with that they would fight tooth and nail not to get the flu vaccine because they're like, I'm going to be off work for a week because I'm going to get sick. Everybody has their own unique response. Right. And so some of the nurses I worked with were like, man, I hate getting the flu shot because I get knocked out. Whereas for me, I'm fine. I don't even know. Maybe a little shoulder soreness from where the injection was. Everybody's a little different.
Yep.
So then what can we expect this year? I mean, every year it's a little bit different. Yeah. The strain's a little bit different.
Yep.
We've heard the news coming out of China that there's this latest thing. I'm going to let you kind of, what is it and what is it similar to?
So what I'm seeing, and this is all anecdotal, I haven't read all of the literature out there. What I'm seeing is that more people are getting the flu and getting sick from it, not necessarily being hospitalized, but spending 2, 3, 4 weeks feeling terrible, just in bed, fevers, all that sort of stuff. So there's something different about the flu this year, or there's something different about the way we're reacting to the flu this year. So I think the prevalence is higher this year than it has been in the past. I don't know that there's necessarily going to be a big wave.
But what does that mean, we're reacting differently to it this year? What does that mean?
Well, yeah, there's some arguments to be made that, people who got the COVID vaccine or who have had COVID, either way, are reacting differently to influenza, right? We've created a whole new immunopathway in our bodies. So we may be reacting differently to influenza than we would have in 2019 before we were either exposed to COVID or got the vaccine. So,
what are your thoughts?
I haven't really done much of research this year. I mean, for me, my kids have been sick the past week, so definitely the fevers, just fatigue.
Yeah.
My busy 3-year-old who's running all over the place. She's like has no energy. Is on the couch. So I definitely feel like this year I've seen it more with my kids as far as like their energy levels and stuff. And I haven't really seen it in the hospital though.
We're not getting a lot of admitted patients in the ICU with respiratory failure. What I'm seeing is more doctors' offices are seeing a ton of people saying like, I've got this fever and I cannot get out of bed. Yeah, I can't shake the fever and I can't get out of bed. So I tell you what scares me more personally is norovirus, though.
You're always scared about
man.
This guy, he's got his sanitizer when he comes out.
And my bucket too. So norovirus is different than influenza, right? Norovirus is what most people refer to as the stomach flu. Okay. And so norovirus, I was just reading up some stuff about this. So back when we were kids, before they had the rotavirus, which is the other big GI bug, they have a rotavirus vaccine now. So most kids get it at like 2, 4, and 6 months of age. So rotavirus is almost gone. That used to be the most prevalent GI bug. Norovirus is the most prevalent GI bug now, and they call it the double bucket disease. Any idea why?
This is a family show.
Yeah, exactly. So all the descriptors say sudden and explosive vomiting and diarrhea.
The word explosive scares me.
So I hate anybody who knows me. I carry around Zofran. I carry around Phenergan. Those are 2 antiemetics, anti-nausea medications. I carry around a bucket anytime I think I've been exposed. It freaks me out. I'm hand sanitizing all the time. Although I just read, have you read this? The norovirus for the past 5-6 years, they think the hand sanitizer doesn't work.
Oh,
yeah.
What?
So they think that the lipid layer, the outside portion of the norovirus, is so hardy now that you've got to actually physically wash your hands to get rid of it. Oh man.
So what exactly is the norovirus? I mean, like, break it down for us medically speaking.
Yeah, so it's a small virus in the I think it's the noro family. I haven't looked back through all the genus and species and all that stuff, but basically it's just a virus that exists primarily in vomit and feces, right? So you're not going to pass it. If you cough on me, I'm not going to get norovirus from you, okay? It has to be in vomit or feces. And so, usually it's you're taking care of your kid who got it at school, who pukes all over the place. You get the particles, and I read something that said you only need 10 particles, 10 total viral particles, which
I mean, that there's like billions.
there's
right?
yeah,
I mean, like,
billions in vomit and feces. So they puke, you inhale it, or you touch your face or whatever,
and that's how it spreads.
and then that's how it spreads. And then people who are sick go to work and prepare food, and you eat the food. That's the other way it spreads. Yeah.
We had it bad last year.
Yeah, New Year's Eve. Yeah.
Oh, man.
Neurovirus.
Yeah.
Knocked our whole family
Yeah.
out. I probably puke maybe once every 5 years, and that was a once in the 5-year event for me. Just vomiting.
I didn't get it last year. So I
think the year before though, your whole family got sick.
except me.
Yeah, except for you. And you're like, because we were working on some staffing issues. Like, I need to have somebody on backup.
Yep.
Everybody in my house is sick.
Yep.
And so every morning at like 4 a.m, I'd text and be like, "Hey, how's it going?" It's like, "Nothing yet. I'm carrying my bucket around."
Yep. Carrying my bucket.
Carrying my bucket.
That's right. Yeah, you should ask
Jeez.
Alicia, my wife, about that. She always makes fun of the bucket. So I was also reading about norovirus. So in a typical year, kind of the average peak is about the same time, end of November, beginning of December, even into the end of December. And typically the peak is somewhere between 55 and 70 outbreaks. They call them outbreaks when there's more than like 15 separate incidents within a certain time period. And the last week they published was the week of December 5th. There were 91. So this year's revving up with the norovirus.
See, here's what scares me. I always get what my kid gets.
Yep.
100%.
Yep.
I mean, like,
You think you have a great immune system until your kid comes and coughs on your eyeballs or pukes all over you.
Yep.
and I didn't know what he had before Christmas break. I thought he had like pink eye or something because, he woke up one day and his eye was like crusty and shut. And I'm like, oh, come on.
Yep, here it comes.
You were on a plane and somebody was puking, right? When you were headed to Paris, right? And somebody was puking on your plane.
So literally we're in Chicago we boarded the plane. Everybody is seated. They closed the door. And once you close the door, you're ready to pull back.
Oh, yeah.
The kid behind us, like 2 rows, like we see like flight attendants running back, attending, and all of a sudden you get a whiff of what happened.
And the engines probably hadn't started up yet, so you don't have the recirculating air.
So the kid puked. Well, we were waiting for them to board the plane, so they must have like ran somewhere from some other gate, and they were the last to board. Well, I don't know if it was that, because then the mom goes over to the son, and he's like, I don't know, 12, 13, whatever, and he feels terrible, right? And she's like, was it like, Qdoba? Was it Chipotle? I'm like, wait, hold on. This is different than you ran from one end of the airport to the other end of the airport. Is it neurovirus?
Norovirus, exactly. That's
Is it you just ate something terrible? Then she asked the dad, who's sitting 1 row ahead of us, how are you feeling? I'm like, oh no.
You're in the firing zone.
So then the biggest question came from the flight attendant. So actually not the flight attendant, the person who was managing kind of the boarding process from United comes on the plane, and she's like, how are you feeling? Not to put any pressure on you, but if he pukes again in flight, we're going to have to land the plane. Oh, jeez. And I'm like, wait, this is new. I've never heard this before.
I've never heard that either.
Yeah.
No, so I don't know if they knew he was not feeling good or had neurovirus or something. And the mom keeps asking, and I don't know if she's a nurse or like a medical professional, because she kind of knew her way around something like this. And she's like, well, just to let you know, like, you have to tell us, like, how do you feel? Do you think we can go? Because if you don't feel good and you throw up again, like, they're going to have to stop the plane.
Divert
and like
the plane to like,
and all these people are not going to get to their destinations. And like, she's having this conversation. He's like, I think I feel good. I'm like, oh God.
You're going to end up in Newark, New Jersey.
No, not Greenland. Like, we're going to end up, right. That's fine. We're going to end up in Reykjavik or whatever. So I'm like, okay, we're going to take a chance. And he luckily felt good the rest of the time. But I wonder if it was
norovirus.
Maybe. But
sudden onset explosive vomiting.
I knew apparently like they had to bring
The vacuum and stuff.
Oh
on the
yeah,
plane.
like they had to undo the gate, like bring in the vacuum, bring in everything else.
Man.
And I've had a kid that's puked on a plane before as we landed, and he did get neurovirus then,
Oh jeez.
and it was bad.
Ugh.
It
Did he
was
make it
bad
in
because
the
Heather
bag
got
at
it
least?
too.
You make it in the bag at least.
No, because this is pretty graphic, but this is a medical
Couldn't
podcast.
get the bag open.
He couldn't find the bag in time, and he looked at me, and his mouth was full, and he's like, and I'm like, hold on, and I'm like trying to get the bag, and it just projectile, and the flight attendants were not that helpful on that flight when we landed in Seattle. So it's a scary thing. I mean, to be traveling with something like that, it makes it hard, right? I mean, like you got to think about all these things that happen.
Good news is though, aside from a very small chance of dehydration, if you really spend several days vomiting and having diarrhea, norovirus isn't going to kill you. It's just super unpleasant.
That was my next
48
question,
hours,
really.
yeah.
Like, is it a virus that could kill you if not treated?
It would be very hard unless you spent several days where you couldn't get any fluids
Just say,
in.
yeah, if you were isolated, didn't have
It'd be hard for you.
fluids, if you're in the middle of the desert.
Yeah, it'd be hard for it to kill you. But it is very, very unpleasant for 24 hours.
So this is a pertinent question, I guess, as we turn the page to 2025. Happy New Year to everybody watching and listening. We asked you this question last year when Kurt from CCI was on the podcast too. Now that we've turned the page into 2025, how do you see anesthesia progressing? What do you see with anesthesia in 2025? What are the trends? And what should patients expect this year?
As far as trends, I read a really interesting article. Actually, somebody who works for CCI, his name's Dr. Dorman. He's our chief compliance officer. He sent an article to me, and there was a stat in there saying that 45% of anesthesiologists are close to retirement age.
Yeah, which is just wonderful.
So I don't think we're going to see any light at the end of the tunnel anytime.
In terms of like relief.
Relief, yeah.
If they all if 45% of them retire, then we've got an even bigger deficit of
And I think if we have
providers.
another event like COVID
we're
was,
done.
it's going to push all those people, that 45%. Because I think COVID pushed a lot of people that were on that edge of, you know what, I'm ready to retire. We have a great CRNA that works for us, JEBS, and thought last night, he's like, look, man, I'm on the downslope of my career. Like, I don't want to be doing lots of
I heard you
crazy
talking
stuff.
hours with him.
Yeah. I think there's a lot of providers that, it pushes them over the edge. It's not just anesthesia. I think it's across the board family practice.
surgery,
People are just getting burnt out.
Yep.
It's a tough environment right now. And, when you look at across the different types of professions that do anesthesia, anesthesiologists, the residency slots, they haven't really increased very much.
Not much.
As far as CRNAs, the Council on Accreditation released stats. I think they have 15 more programs opening this year. So everything that the National Association is saying is that in the next 5 years, we should see some relief from the CRNA side of things. But I don't
buy it.
You
gonna be
don't?
longer than that.
I think we're in all these baby boomers. We have an aging population.
So what's going to happen though? I mean, like you need CRNAs and anesthesiologists.
You want the macabre truth? The macabre truth is when the baby boomer generation dies out, it's going to improve. We're going to need less care. It's just the way it is.
Yeah.
How is that so though? Because our generation, Gen X,
we're healthier and there's less of us.
So you look at like generations, the baby boomers, like my parents are at the tail end of the baby boomers. They're just retiring. So think about for the next
15 to 20 years.
15 to 20 years, there's going to be huge demand. But when you look at like birth rates, there's obviously been a dip since the baby boomer generation. Our population is not replacing itself.
Right.
and are less people going to receive care? Like,
I don't think that we're not going to have rationing. I mean, we're going to take care of people.
But no, I mean not in unintentionally, I guess, but intentionally. So like our generation, as opposed to the baby boomer generation, if I get a cold, I'm not running to the doctor's office. I'm not getting surgery immediately, right? I mean, like, also the spread of wealth, right?
Correct. Yeah.
I mean, baby boomer generation,
Held it all.
yes,
Yeah.
had wealth.
Yeah. It's true. No,
It's
and they're
very
going to disperse that. I was reading an article about how they're going to disperse that between Generation X and the millennials in the next 10, 15, 20 years. All that wealth that they've
Is gonna be
generated
spread out.
is going to get spread out. I think it's going to improve when the baby boomers. Again, my parents are baby boomers. I love my parents. My
Yeah,
in-laws
same.
are. But once the baby boomers die, I think we're going to be in a better place in terms of not only medicine in America, but financially in America. Because again, all these people are retired and basically living off Social Security, which we're all paying into, and they're not contributing to society anymore. You also look at Generation X. Some of the Generation X are now moving into the retirement age, and they're still working with no plan to stop working. I don't think that the generations after the baby boomers expect to retire at 65 and just be done. So
I agree with Brian. I think there's been a trend where people want to work longer.
You think so?
Oh yeah, I think because I'm a millennial. Yes, I know I'm a millennial. I think
A
for
true
me-
millennial. You're not a
true millennial.
xenial.
Yeah.
No,
Yes,
I'm a
yes.
true millennial.
dead center, I think.
Yep. I think the new a centennial is what they're.
Oh, geez.
Neil
But no, I
Strauss
think-
is
I
in his
think-
grave.
Like for myself, I'm not planning on Social Security being there.
Right.
It's not going to be there for me, even though they say it's going to. So I think a lot of us, our generation that we're in, is we're looking at work and saying, where can I do work that I can do for a sustainable amount of time? You also have a lot more of our generation who aren't what I would call blue collar. They're more
Yeah.
technical. They're not doing that hard labor. They're not beating up their bodies every day.
They're taking more vacation.
They are taking more.
It's true. No,
They're
I'm-
taking way
yeah.
more vacation than the baby boomer generation. So
if-
there's more like give and take of.
But look at productivity. The productivity of Generation X and the millennials is way more than the baby boomers because
I'll say Gen X for sure.
we're better at using No, I mean production. I'm not saying I'm saying per year
Yeah.
productivity. We are doing more. Gen
With
X and
less.
millennials are doing more in less time. We might take 10 weeks off, but we're doing as much or more work.
We are 100% using all of our
Exactly,
vacation.
exactly.
Yeah.
But we're doing more work. And I think part of it is we're learning how to work smarter and not necessarily just clock in. I'm going to clock in every day at 7 a.m. and clock
Bring
out
my
at
lunch
5
pail
p.m.
and-
right, exactly.
And you're going to work for the same company for
Right.
40 years.
Yeah, that doesn't happen anymore.
That doesn't
for sure.
exist.
No. I mean, what is the average? And is medicine,
2
is
to
it
3
is
years.
medicine, is it different in medicine or is it the same?
I would say it depends on the specialty.
Yeah.
When you look at anesthesia, I think it's people move all
Bounce
over from
around.
job to job. But when you look at somebody like an orthopedic surgeon or a surgeon who has to establish a patient population, if they have a great patient population and they're staying busy, they're not going to want to ruffle the feathers. Whereas with anesthesia, we're really a commodity.
Yeah.
I always joke, I always say it's like a piece of OR equipment.
Yeah.
We don't have a patient population that follows us. So, I always joke with providers, say, look, you're young in your career. The grass is never greener on the other. It's not always the greenest, and don't burn bridges because in anesthesia,
Small
we
world.
know everybody.
So with that in mind, how are you building this company in 2025? I mean, as you're looking at what, year 4, 5?
Yeah, 5. I mean, if you go all the way back to when I started, it would have been 18.
With all that in mind of, hey, like this isn't the baby boomer generation where people stick it out for 40 years. The expectations have changed.
Yeah.
You're probably getting younger in your company
Yes.
every year.
I would say that's true. Yeah.
I sat next at the dinner last night. I sat next to somebody who was graduated college in 2009,
Yeah.
right? I
Yep.
mean, like,
Yep.
so it's getting younger.
Yeah.
How do you make those adjustments and build a company around that? A medical company.
Yeah.
around that?
For us, I think we've gone the opposite direction of most companies where we kind of cater to their availability. So we are not a traditional set in stone. You work this many weeks, you have this many weeks off. It's more of, hey, we can use you. We have needs. And that's what makes us unique with our staffing side of things is because Brian and I both know, like, on a day-to-day basis, this is about how many providers we need. Yeah. So we always are reaching out to them early and building up to that X, you would say. And then If they don't work, then they're not getting paid. But at least for them, they have that flexibility. I think as well, a lot of providers have been burnt by other anesthesia companies, and they feel a little insecure, and they don't want to be stuck in one place and have to deal with a non-compete. That's a whole nother topic that we can talk about.
Right.
But yeah, I think for us, it's just trying to be unique and just building our schedules around the provider's availability. Obviously, we have a great core group of providers that are hardworking, that want to work X amount of weeks, and then we build around that for the rest of our stuff.
And we just say, hey, give me your availability for the next 90 days. You're credentialed at 15 places. We're going to send you to one of those 15 places every day that you give us availability, and then it just plugs in. They like the flexibility of, oh, well, today I might be at a big hospital doing a god-awful sick person, and tomorrow I might be doing cataracts.
So if somebody, it was a shameless plug for JEBS, but, like if somebody wants to look into working with you guys and for you guys, how do they go about doing that?
Hit up the website or contact one of the two of us.
We've got a website, JEBSAnesthesiaConsultants.com. Yeah.
And
We've got our contact information there. As well, like we talked earlier, there continues to be more and more needs. I mean, we're constantly...
And opportunities, right?
Opportunities, for work. I always joke with people. We always joke, hey, I could use a couple, it used to be
100 more.
100 more. Now, in the areas we're in, it's like, hey, we're doing great. But now, like, as we move farther south into Indianapolis, I'm like, man, we need more work down there, because I've got all these providers that want to work, and you're trying to be fair and spread the workload across all of them.
I feel like this is very similar. I mean, there's a lot of specialties out there, not even in medicine.
Yeah.
Like if you look in TV, good luck trying to find a broadcast engineer. It's a dying breed, right? I mean, if you're a broadcast engineer, first of all, you could pick the litter of any job you want around the country. They're looking for specialties and specialists that have that type of knowledge. And where are you going to find that?
Yep.
And I feel like CRNAs and anesthesiologists are very similar to that. It's like you have this very specialized field, and so much, but you have the pick of the litter. I mean, like, you're really, like, you could do anything.
Well, and it's plug and play.
Or go anywhere.
It's plug and play, too, right? So it may be the same for a broadcast engineer, but a facility can call us, and Bronson and I can walk into any facility tomorrow that we've never been in before, and in half an hour, we're able to start doing cases. So, that's not something that you can always do with a surgeon or with a family practice doc or whatever. I mean, we're really plug and play.
So it's good to be an anesthesia in 2025.
Yeah.
Yeah, I mean,
I'd say so.
It's great. There's goods and there's bads.
Right.
Yeah.
We've talked about this, about how we have been squeezed by the insurance companies for our reimbursement, and then that puts a lot of the onus back on the facilities. And before, the facilities never felt that. We could work at a surgery center with good private insurance companies and make a good income and not need to be subsidized, whereas now there's such a squeeze. Yeah. So definitely a lot of listening and, letting them know that we understand their concerns. But, we always talk about the first thing is we're going to bring high quality providers in. We're going to cover you, and then we're going to work on costs. Cost is going to come third when you have quality and coverage.
Awesome.
So what about HMPV? We didn't even talk about HMPV.
Oh, yeah. Let's finish off by talking about that. We have a few minutes.
I don't really know much about it, aside from it seems to be a flu-like virus. It's been around in China since 2001, but I think it was the Daily Mail and Newsweek and all these big magazines are making a big deal out of it. So just to be on the cutting edge, if HMPV starts to come out in the United States, it might be the next COVID. Yeah. Well, that's so in terms of
sounding like a physician now,
in terms of any virus of any kind, wash your hands.
Yeah, I think this virus is a droplet precaution. Yeah. Just like what COVID was. Yeah. Droplet. So, I mean, I think anytime anybody hears a virus in China, our ears perk up a little bit, unfortunately, with the political environment that we live in these days.
Yeah, it's called flashbacks.
Wash your hands.
Yeah.
Wash your hands.
What I was reading, too, is mostly it's affecting kids younger than the age of 14.
Oh,
so,
really?
Yeah.
Because they're lungs are
They
not
don't know.
as developed, or
They don't
No,
know.
they don't know.
And they're seeing a lot more just pneumonia, which, it sucks as a parent when your kid has pneumonia, but luckily it's not like COVID where like the healthy young people had some minor symptoms and
Yeah.
they were fine, and it was targeting mostly like those who were morbidly obese, had
And sick.
type
and,
2
yeah,
diabetes.
And dying, yeah.
From what I'm reading, it's not that. But once again, we're post-COVID.
Yeah.
We hear something from China. Also, we are coming into a new administration. It brings back flashbacks
Yeah.
of 2020.
yeah. Who do you guys trust in terms of resources out there?
Ooh, that's hard. Nobody really.
Yeah, right now, ugh.
I mean, you can't. Personal opinion.
TikTok? I mean,
Yeah,
like,
I mean-
literally, like, who do you trust when it comes to CDC?
No,
Like,
I don't trust the CDC or the NIH. No, not at all.
No,
I mean,
I don't
they're
either.
they're politicized too. I mean, you kind of have to go and look at, and we'll talk about this in a
Yeah.
upcoming podcast. You've got to go look at the primary literature coming out of, basically politicized labs, like, let's say, for instance, University of Notre Dame.
yeah.
So
Good shameless plug.
thank
there.
you.
Right. Yeah.
I got one more shameless plug for my new energy drink.
Yeah.
Yes.
Oh, yeah.
So,
Go ahead.
there you Yep, Aspire. These
Oh yeah, Bronson, you got one too. Hold it up.
this company sent me some of these, and I generally get headaches and stomach aches from energy drinks, but not this. So.
Wow. And it works. Like
Try
it's
it
a true and
Yeah, it's got
tried and true energy drink.
Yeah, I think it's got like 80 milligrams of caffeine, which is plenty for me.
Nice.
So, yeah.
Did you read all the warnings on the Surgeon General and how much caffeine you should consume in a day?
No, that's not on there, is it?
Yeah, it is.
Oh, not recommended for children or people sensitive to caffeine.
And it says
Well, yeah.
the FDA suggests limiting daily caffeine consumption to 400 milligrams.
This has only got 80. I could drink 5 of
I
these.
know, but who drinks less than 400 milligrams of caffeine?
I'll probably get close most days.
I do too.
Yeah,
With the amount of coffee, tea,
Yeah.
Coca-Cola
Pre-workouts.
Zero,
Yep.
pre-monsters. I mean, there's no wonder.
Yeah.
All right, guys.
Yeah.
Well, thanks so much. And if you want to find more about JEBS, again, what's the website?
JEBSanesthesiaconsultants.com. And
Bronson.
then obviously social media, Brian.
Yeah.
Happy if there's a CRNA out there who would like to talk to a CRNA, we can get connected.
Yeah.
Yes, you can. And of course, we are brought to you by
Butterfly IQ. IQ3.
the Butterfly IQ3. And this has been Going Under Anesthesia Answered with Dr. Brian Schmutzler. I'm Vahid Sadrzadeh with Bronson Taylor. Welcome to the new season. We'll catch you next time.